Okay, guys, we're going to go ahead and get started. Hello. It's 2:30. We're going to go ahead and get started. Hello, hello. So I'm going to start by telling you guys a funny story. So sometimes we go to, we have conferences in really nice places. Toronto's a lovely place. And we had one in Hawaii when we went to Hawaii, and we were hosted by the Queen's Medical Center. Well, I am like super white. I am not tan in any way. There's nothing about me that's tan, but I had this vision of wearing, you know, being able to go to some of the events in a little Hawaiian dress, and I saw myself as tan, and that was going to be just this wonderful thing. Well, so I decided what I would do is I would get one of those spray tans, because I don't want to like subject myself to all the sun and all the bad effects of laying in a tanning bed. And so I went to the tanning salon, and I had this girl at the front who was probably 12, maybe 14, I don't know. She certainly wasn't very old, and she was smacking gum. And I told her I'd like to try one of their tans, one of their spray-on tans, and she said, well, which one do you want? And I said, well, I'll you know, which one do you recommend? And she said, well, you're pretty white, so. And so she recommended that we go one shade up from like the bottom. So I would just have a nice, she called it a glow. And I said, okay, great, I'll take the glow. And then she didn't tell me very much, just that when you go in the booth, you put the stuff on your hands so that your hands aren't super brown, and you go in the booth, and then it's pretty easy. You just follow the instructions. And I said, okay. So I did what she said. I put the stuff on my hands, and I went inside the booth, and it said, press the button to start. Okay, that seems like so easy. I'm like, oh my gosh, this is so easy. So I'm standing there, I press the button to start, and it goes, and I thought, oh my gosh. And then it goes beep, and I'm like, what is that? And then it went again. So you guys can probably imagine what happened. Like, I am so horrified. I turn around, put on my clothes, I go to walk out, and the girl's like, you okay? Everything go? And I'm like, it's fine. And so I just got my stuff and I left, and I went home, and of course I told my husband, what are we gonna do? I'm only sprayed on one side. So I'm like really brown, super white. So we spent a couple days trying to like spray on that stuff from the drugstore to like even it out. And that doesn't go well either, by the way, not a good idea. So if you're going somewhere to speak, don't get a spray tan. Okay, we're going to go ahead and get started. This is a topic that's like near and dear to my heart, and we're going to talk about benign tumors. But you know that really depending on locations, these can really behave in a very, very malignant way. So we're going to talk about that for a few minutes. So again, my home away from home. And really, I want to just start by talking about what do we think that makes a tumor benign. It's really the pathological characteristics. When we think about it in a very, very condensed way, the cells look like normal cells. When we look under a microscope, it's kind of like a Me Too tumor. It looks just like our cell, but slightly different. And so here we are. We have our little neuron, and it looks exactly the same on the other side, just slightly different. So the growth pattern, these tend to be slow growing. They also are defined, they have a defined region of growth with a circumscribed border, and they rarely spread. So when we think about something really, really difficult like glioblastoma, we know that those don't have a defined border. They spread like crazy. They actually can double in size within 2 weeks in some cases. So GBM is just really, really hard to treat. A meningioma, on the other hand, very, very slow growing for the most part. Of course, there are atypical meningiomas that can behave in a very malignant way. That's why why when we guess about what we see on a screen, most people would look at a homogeneously enhancing extraaxial tumor that's sitting in the brain. They would say that's a meningioma, or a meningioma. It's one of those. But we don't know is the growth associated with that meningioma. They can be atypical. So tumor grading is really based on the following variables. We know that we have the WHO grading system, and that's grades 1 through 4. 4, not good, really, really, really bad. Grade 1, that's your lowest grade, and those are typically associated with longer survival. So what they look at is they look at similarity to normal cells. That's called atypia. The rate of growth, or the mitotic index, the features associated with uncontrolled growth. When we see things that are associated with uncontrolled growth, it's usually a blood supply issue. There's angiogenesis going on, where you're actually increasing the vascularity to the area. And then, of course, evidence of necrosis. Those are things that we see in the setting of GBM. That's because it outstrips its blood supply. It actually grows so fast that the center becomes necrotic because there's not enough blood supply for the amount of growth that's going on. So these are the 2 grades I'm going to focus on today. Those grades 3 and 4, those are high-grade tumors. These grades 1 and 2 are typically are slower growing. So grade 1, very slow growing. Grade 2 is relatively slow growing. Grade 1 looks similar to our normal cells microscopically, and then there's a slight abnormality when we look at it microscopically in grade 2. The grade 1 has the least malignant features, and the grade 1 has the least malignant features. Grade 2 can invade the local adjacent tissue, and that's important. So when we look at the margins of the tumor under a microscope, that becomes important to try to figure out whether or not it's grade 1 or grade 2. And then grade 1 is usually associated with long-term survival, and then grade 2 can recur as a higher grade. So when we see gliomas in particular, and they come in as a grade 2 and the person is 25, I really worry that that tumor is going to progress at some point and that they're going to end up with a grade 3 or a grade 4. So why is all this important? Really because of what we know about the brain, what we know about the Monroe-Kellie doctrine. So we know that we have an 80-10-10 rule, and I like to think of this as I see an expensive pair of shoes and it's a size 5. I am not a size 5, but would I like to get my foot into that size 5 shoe? Yeah, sure, but if I try to cram it in, only so much is going to fit. It's the same with the brain. It's in a rigid box. So you have 80%, which is brain. You can't get rid of that. That's important. We're not going to get rid of the brain. The blood and the arterial venous is 10%, and then cerebral spinal fluid is 10%. And that's how we end up with looking at ICP, or intracranial pressure. If you add a tumor on top of that, that actually doesn't fit inside the box at some point. So the tumor types that I want to just briefly touch on, we always think of as good tumors. They're not really good tumors, and part of this is related to a recurrence rate. It's related to age at onset. So meningioma, the 5-year survival rate is 69%. Part of that is related to the recurrence rate of meningioma, and we'll talk about why that's important. Cranial nerve tumors, there's a 91% survival rate, and the pituitary adenoma is 74%. So when we think about meningioma, again, it's either benign, atypical, or anaplastic. There is an anaplastic form of meningioma. And when we look at the scan that I have there, I'll talk about radiographic features, but you can see that there's displaced brain, and it's actually attached to the dura. There's usually something called a dural tail too, and we'll talk about what that looks like. So these are features that we want to see. When we think about meningioma, we want to see a homogeneously enhancing tumor that is superficial and attached to the dura with a dural tail. And there's sometimes also bony involvement, and I'll show you some examples of that. So I obviously put those horns on there. Those aren't real. I just thought it would be fun. So this is actually a meningioma that's actually at the olfactory groove. And this olfactory groove meningioma this is all tumor. and it's displacing upward. This was a young man who was a golf instructor who presented with his first ever seizure. That's how he presented. And we scanned him, and there was this gigantic thing sitting in his head. That's not going to stay. That has to go. The small meningioma in the back, if this was, and age is so important, right? I mean, if this is a 88-year-old female who has congestive heart failure, is non-ambulatory, lives in a skilled nursing center, I don't know if we should take that out. We should probably just leave that. I mean, they're not having any seizures, they're completely asymptomatic otherwise. This is someone we might choose to monitor radiographically versus this gentleman who presents with a first ever seizure. Whether or not that's benign is not important. It needs to come out. So meningioma has a very specific radiographic signature. The features are actually homogeneously enhancing, it's extraaxial, and then MRI is not helpful in discriminating grade or histopathology. So when you look at that, you can't tell, is this atypical? Sometimes you can actually see some intratumoral cystic change that can help in sort of distinguishing, but I've absolutely seen meningiomas that look for all the world like normal stuff, and they turn out not to be. The other thing that I see recur over and over again, and I don't know if you guys have seen this in your practice, but people who've received craniospinal radiation as a child who for ALL, or I had one very unfortunate woman that's in our practice right now that I didn't realize they even did this, but years and years ago when radiation first came out, they believed that it was good for treating like a scalp irritation. So they would radiate young children and to get rid of the scalp irritation, like a fungal tinea on the scalp. And now she has like 6 meningiomas as an adult. All of her hair is gone, and that was all from scalp irradiation as a child. So this is the radiographic. I've given you examples that are like super obvious so that you just pick up the concept. And so what you can see here is you can see a meningioma that actually involves the bone. And I have seen a patient come into our practice that way, and literally they look like the cone heads. And I don't understand how his primary care provider didn't like notice that over time he's developing this gigantic cone on his head. And I asked him, how long has this been going on? You know, like you have notable changes in your skull, the way that it looks. And he actually was nearly bald, so it was so obvious. And he said, well, I went in a couple times and my primary told me not to worry about it. And so it had been going on like 5 or 6 years. And this would have been much easier to resect if we had caught it earlier. But now it involves removing all of the bone, not some of the bone, all of the affected bone, and doing a cranioplasty, as well as looking at the venous flow, right? Because that's right on top of the sagittal sinus. So is his sagittal sinus even open now, or is it occluded? Is it partially open? Do we need to try to preserve that and get what tumor we can? And so that's really, really an important finding. Also, here we have a large meningioma, but what you can see is you can actually see shift of the intracranial contents, and that does not have as much bony involvement. And so that's meningioma. And they can occur in a number of places. These are sort of the common locations that we see meningioma occurring. This is the typical, oops, maybe not. Typical craniotomy, the old-fashioned way, right? There are lots of new ways that we're going to talk about for removing meningiomas or even treating meningiomas. How many of you guys use gamma knife radiosurgery as a primary treatment in meningioma? So we don't usually use it as a primary treatment, although in certain patients we do. So patients that are quite elderly, that are non-surgical, that have poor surgical risk, or really, really poor candidates for surgery, we will think about gamma knife radiosurgery as a means of controlling tumor growth, because that's what it's going to do. It's not going to melt the tumor and make it go away. It's going to control tumor growth, and it also has to be a tumor that's less than, we really don't like them any more than 3 centimeters. 3.5 is kind of pushing it. They will swell, and they actually continue, the radiation continues to work over 24 months, 18 to 24 months. So it's not something where you just zap it and that's it, you know, fix it and forget it. It's not that at all. So this typical craniotomy is a frontotemporal approach with making a window in the bone and then being able to pull back the dura, resect the tumor. And we do remove the tumor and the dura in that situation. If it's infecting bone, all of the bone has to go. So this is just a brief overview of what surgical treatment looks like. This is an 82-year-old male with a right frontal meningioma. So another just word to the wise, there are, of course, typical locations that can be epileptogenic. So the frontal lobes don't like to have a tumor in the way, and they absolutely will produce tumor. The temporal lobes don't like something in the way. Other locations are a little bit more resistant to seizing. Posterior fossa, not so much, but certainly the cortex does not like something in the way. So this is just an overview of a craniotomy. This person had no hair. We, of course, do hair sparing at this point. We only remove just a slither of hair along the hairline. And what's so interesting to me, and maybe you guys have encountered this in your own practice, is that patients, I counsel patients every day about brain tumor. They come into our practice, brand new diagnosis. I talk about what a brain tumor is, what we think their pathology might be based on the radiographic characteristics. And the number one question is what? What about my hair? I'm like, oh my God, who cares? We can shave it all off, but what about my brain, right? Can I talk after this, after I have this removed? But number one question, what will happen to my hair? Oh no. So funny. So this is just an overview of what craniotomy looks like. You can see that they've drilled some burr holes and they're ready to remove the bone. This is removal of the bone. And this is getting down into where the tumor is to resect. This is, of course, neuronavigation. Everyone's using neuronavigation these days, so they all get MRIs that allow us to very, very precisely get down to where the tumor is and just identify tumor tissue and then be able to resect that only. So we use this little, it's like a little wand, and we're able to touch where we're at in the brain, and it co-registers back to where the MRI is and where we're at in the brain. The one thing that I would say you have to be cautious about with neuronavigation is intracranial shift. If your operation goes on for a long time, or this was a gigantic tumor, there can certainly be shift of the intracranial contents during the surgery, and that makes that neuronavigation a little bit less accurate. So this is resection. They've removed the tumor, and they're ready to go. I want to talk about a few other things that we're typically doing now, and you guys are probably already adopting here as well, which is surgical options that use natural corridors. So either the nose to approach a tumor or using the eyebrow. And so we're routinely doing that at this point. One thing you have to be able to consider about eyebrow approach, and this is actually a beautiful picture of an eyebrow craniotomy. This is the craniotomy here, right through the eyebrow. It's a 1-inch incision through the eyebrow, and they make a little tiny window. It's great for a couple things. It's great for aneurysm located in an anterior communicating position. It's fantastic for frontal meningiomas. It can be removed in that way. The one thing I would say is that if you have a large frontal sinus, that's a bit of a barrier, and you do have to think about packing the sinus after the surgery. Ports can also be used. We rarely use them, but do use them some. And then meningioma, just to touch on kind of survival, it's of course better if you're younger. That's true in most cases, right? So GBM survival is better if you're younger as well. 81% of patients aged 21 to 64. And 56% in patients that are 65 years or older. The 5-year recurrence rate is 18.2 to 27%. And then location is an important variable as well. Thinking about proximity to the venous sinuses, brainstem, the sella, the optic nerves, and then olfactory as well. Olfactory groove meningioma, if it's approached endonasal, completely wipes out sense of smell. And so that's important to know. That's a big thing, because what that translates into is people can't taste their food. And tasting cardboard for the next 40 years, that's a big deal. And so we really try to adequately counsel patients when they decide on that approach. We can get the tumor out that way. It's a very safe and effective way of removing frontal or olfactory groove meningiomas. But when we go through the nose, we often do disrupt the olfactory nerve, and then it results in a problem with sense of smell. Meningioma carries a very high risk of DVT. All cancers actually increase hypercoagulable state, and so you should be aware that that's something you have to watch for. We will hydrate them, make sure that they're up and running right away, that they're walking, because they have a very, very high rate of DVT. Okay, so Simpson grading actually looks at the completeness of resection, and it gives you a prediction of the 10-year recurrence rate. So grade 1, we got every bit of it out. That's what you should be thinking. Complete removal of and resection of the underlying bone and the dura. There's a small risk of recurrence. How many of you have taken care of a meningioma patients and said after they had the resection, "You're good, it's all out"? Because I used to think that. I actually used to think that that was it, and they had it removed. It's a surgical treatment, and these patients are now cured of their meningioma. They need scans every year. They are not cured. They absolutely can recur. And so we do double the screening interval. When we see like 5 scans in a row that are nothing, we double or triple the screening interval, but they absolutely can recur. Some reasons why we might not keep screening is the patient is very elderly and we have no plan to ever resect them again. Recurrence or not, we're not going to resect you again. You are 85 years old, and it doesn't make sense at this point to continue on with screening them. We've taken out the tumor, and these are high-functioning 85-year-olds. These are someone I was playing shuffleboard yesterday, and then I had a seizure kind of patient, as compared to a very debilitated 80-year-old that we don't think will do well with the surgery. Those are patients that we think about more palliative approaches. So atypical meningioma, this is the WHO grade 2, has really variable histopathology and clinical outcomes. It's really unclear what we should be using, but we typically will offer the option of stereotactic radiosurgery. There's kind of pluses and minuses, and we almost always offer it as an option. And then there's several case studies and some that look at a mean treatment out to 52 months that say that survival is better, and there's a lower recurrence rate with radiation after. The next thing I want to move to is actually another very, very common benign tumor, and this is vestibular schwannoma, and this is affecting the 8th cranial nerve. You see that also concomitantly with NF2. So if you have NF2 patients in your practice, you should be thinking these patients commonly develop vestibular schwannoma, and they commonly develop it bilaterally. So they can be very, very, very hearing impaired, and the tumors can be huge. They can also compress. Keep in mind it's the 5th and the 7th and the 8th cranial nerve are relatively close to one another, so it can cause compression of the 7th, so they can have bilateral facial weakness. They can also have trigeminal neuralgia from compression. So those are important things to keep in mind. And what it is it's actually this is an example of actually NF2. So you see that these huge things here are both vestibular schwannomas related to NF2. And anytime I see that scan, I know that's what it is. It's not like, a surprise. I know that I'm seeing an NF2 patient when I pull up that scan. So what are the imaging characteristics that are important? So the dumbbell shape of the tumor, and it's at the level of the 8th cranial nerve. And you can see this actually indents the pons. This is the pons here, and it indents it a bit. And then usually there's intracanicular tumor as well, so it goes into the canal. Pretty typical. And what we've really largely done is move away from neurosurgery unless the tumor is big. Tumors that are big usually come out surgically, and others we typically treat with Gamma knife at this point. Well, so I just said this. I got ahead of myself. But there's less morbidity, there's similar control rates, but it's not used for large tumors, so greater than 3 centimeters, that's an issue. You really shouldn't be treated with Gamma knife radiosurgery. And then the recurrence rate after gross total resection or near gross total resection is 9 to 20%. And then Gamma knife, there's 7% tumor progression. So it makes more sense to maybe manage it this way. There's a 30 to 50% chance of deafness, and then a 1 to 3% chance of facial nerve damage. Most people with vestibular schwannoma have some hearing loss. That may be why they presented. They may have presented with ringing in their ears. I find now in my practice, it's a lot of incidental findings. So people had a car accident, they were complaining of a headache, they come in, they get scanned, and bam, there it is. And it's small. They're not even symptomatic yet. I usually get an audiogram, try to figure out if there is any baseline hearing loss, and then we talk about treatment options. It's a much more sort of gentle approach to how to manage the tumor. We can talk about options. They can think about it. They can see a otolaryngologist. They can look at all the literature regarding the options of gamma knife radiosurgery versus open surgical techniques. There's certainly there's a medial approach that is a hearing preservation approach, and then there's a suboccipital approach, which clearly wipes out the hearing on that side. How many of you have seen facial weakness too after someone removing a large vestibular schwannoma? It's a really big problem, right? And so anatomically very, very close to the facial nerve. And so complications that we see is permanent hearing loss associated with surgical care. But what are you going to do? This is not a lesion for gamma knife radiosurgery. That is going to be trouble every single time. It's going to swell, it's going to compress the fourth, you're going to get obstructive hydrocephalus, and you're done. And so that's not really a good case for gamma knife. There's also difficulty with gait and balance. You probably have seen them. They have a lot of cerebellar problems after having this type of surgery, nausea, vomiting, difficulty with gait and balance. They also can get obstructive hydrocephalus even after surgery because of the anatomy there, and then facial nerve can be transiently or permanently damaged. So this is an example of a facial nerve palsy, and I really want to stress this is such a big deal. I know that we see it every day and we don't think as much about it, but the cosmesis of that and living with that every day, that is disabling. That's a really big deal. They also, it interferes with effective swallowing and it predisposes them to aspiration. They also can get exposure keratopathy, and if you have not seen that, oh my goodness, that's awful. It's really, really, really bad. I had a patient back in clinic, and she had a vestibular schwannoma removed, and she didn't really, I don't know if she didn't think about calling back in, but 2 weeks later, she comes back into the clinic, and her eye was completely red. I couldn't see anything of the eye. And I emergently called ophthalmology, and we admitted her, but oh my goodness, what a bad exposure keratopathy. She lost vision in that eye. It's a really, really big deal. And then also loss of self-image and depression or issues. So the risk is 4 to 15% after open surgery and 1 to 3% after gamma knife. I want to just touch on hearing. People also sort of minimize this as a problem, but this is really a big deal. And so I don't know if this is going to work. I'm going to take a chance that it will. This is actually looking at normal hearing, slightly impaired hearing, and very impaired hearing. And I want to touch on the importance of understanding speech discrimination and the role that plays. Because if you're in a busy restaurant or in an area where lots of people are talking, you have no idea what's being said, it is very socially isolating because you can't ever go out to dinner. I mean, you're like, I don't understand any of the conversation. I can't participate. It's a big deal.
When the sunlight strikes raindrops in the air, they act as a prism and form a rainbow. The rainbow is a division of white light into many beautiful colors.
That's normal hearing.
When the sunlight strikes raindrops in the air, they act as a prism and form a rainbow. The rainbow is a division of white light into many beautiful colors.
That's slightly impaired.
When the sunlight strikes raindrops in the air, they act as a prism and form a rainbow. The rainbow is a division of white light into many beautiful colors.
And that's moderate. And so when you see someone with moderate sensory neural hearing loss, they have a lot of background. They can't hear. If there are lots of things going on, they really have difficulty hearing. And so just be aware of that. And all people with vestibular schwannomas, the type of hearing loss that they have is not conductive. It's actually sensory neural. This is just exposure keratopathy, and it just focuses on how important really nursing care, basic nursing care. This is not hard stuff. This is the easy stuff. So artificial tears, and we do it every 2 hours. We tape the eye closed. We also early report any redness at all so that we can get on top of that because it can cause blindness. For treatment failures, we do tarsohaphy, where we suture the eye shut until the nerve recovers. And we also do Botox injections to chemically close the eye, and of course that wears off. And so hopefully then at some point when they're better, their eye will be able to open and their vision will be preserved. And that's just showing you what tarsohappy looks like. And this is the injection areas for Botox. So just quickly on to pituitary adenoma. About 7,000 people are diagnosed annually. There's a 50% recurrence rate after subtotal resection and 21% after gross total resection. 10-year progression-free survival is 59%. And there are some secreting, and those are largely prolactinoma. So the prolactinoma patients, that can be medically managed. So if you have a sky-high prolactin level, and just thinking about your prolactin levels, you want to be asking yourself, when someone says the prolactin level is high, we get lots of referrals and they say, oh, this is a prolactinoma, the prolactin level is high. And it's like 100. That's not a high prolactin. That's actually just probably stalk effect from the tumor pressing on the gland. And so what we look for is prolactin levels that are in the thousands. And those people do respond to cabergoline. That's our drug of choice. And it's usually dosed twice weekly. So this is our approach. It's endoscopic endonasal to get to a tumor in the nose. And this is just the anatomy. I actually, I know that I'm not a surgeon when I go in the OR and I feel like nauseous. When they've got the ultrasound in one hand, they've got the endoscope in the other, and I can hear the carotid. They're like right up against the carotid operating. And so these tumors are right here, and there's your carotids on both sides. It flanks the tumor. This is just a better view. Whoops. Okay. Perhaps I'm done. That's okay. Dawn, can you tell me how much time I have left? Okay, great. Thank you. 15 minutes. Okay. Okay.
If you want to keep talking, if not, I can talk.
10 minutes?
Sure.
Okay. Just trying to find my, here we go.
Just say download, Christi.
Okay,
Yeah. So if you don't, it won't.
okay. I wonder why it's doing that.
Leave it on your laptop.
Yeah. Ah. Okay. Oh. Well, after I get every font known to man, we'll go on with the talk, right? I know, right? That's what I was thinking. Clear. No. Stop. Okay. It's having a heart attack. Don't send. Okay. Okay. Back. So this is just showing you all the blood supply and the amount of nerves that are in the medial cavernous sinus. When you have cavernous sinus involvement of a tumor, it's a big deal. It's not something small, and it's not easy to resect, and largely these are unresectable. And this is just what that looks like anatomy-wise. These are all the vessels that are around it. So when you think about that, it's really an elegant surgery. It's a beautiful technique, but you have a lot of important real estate right there beside where you're operating. So the surgical complications that we think about is persistent CSF leak, and I'll show you a case that actually had that. So no nose blowing, no IS, no straining, incentive spirometer is what I mean when I say IS. Pan hypopit, that can certainly happen. We absolutely require that they follow up with an endocrinologist after their surgery. Visual loss, and we want to do a really, really thorough visual exam before we operate on these people so we get a sense of whether or not they have baseline visual field problems. And what we're looking for is bitemporal hemianopsia, because that's what they get. They also can get loss of color vision, and so you also want to look for that as well. Diabetes insipidus, this is actually something that we see after our big resection sometimes. Pretty rare though, I would say. Most patients tolerate it pretty well. But what you're looking for is really excessive urine output, and it looks like water. And then, of course, we're looking at the spec grab on those patients. So I just want to talk about, how we identify which one's going to be a problem. So can you predict which one of these tumors is going to be a problem? I'm going to point out the tumor. This is the tumor. It's just not got contrast. This is the tumor here, and then this is the tumor here. So which one of those do you think? So is it the one on the right, the left, or the middle? Anybody want to guess? Which one will get into trouble? So it's actually this one, surprisingly. Gosh, right? I mean, it's so tiny. You would think that they would totally tolerate it. But this is a patient that presented. She's a 42-year-old female who had headaches. She received Gamma knife. She got 18 gray to the 50% isodose line. She presented for follow-up in 6 months, and she was complaining of continued headache, dizziness, right-sided weakness. And then she collapsed in the office, falling and fracturing her nose and right hand. And so this is her. And so this is her scan and follow-up. So what went wrong? There's a ton of vasogenic edema from the Gamma knife radiosurgery and 18 millimeters of midline shift. So we ended up putting her on dexamethasone, which immediately she improved. And then we just surgically resected the tumor, and she did great. She was discharged in 4 days and then had a nice follow-up. So this is another patient. This is that 23-year-old golf instructor I was telling you about at first, who presented after an auto V-tree. We're a trauma center. I'm coming from a level 1 trauma center, so I see all the trauma cases. And that's actually why he came to our hospital, because he was an auto V-tree. And then he was very, very kind in that he then suddenly seized on the scene, and they're like, oh, there's a neurological problem. Had he not seized on the scene, would he have gotten all the imaging? Because he actually woke up and started talking and was fine. I'm not sure he would have. We were really lucky that he just showed us the problem on the scene. And he ended up with a large subfrontal meningioma that was noted on imaging, and so he underwent a surgical resection. Everything went fine, and we actually at the time had nursing coverage from a clinic that was an oncology clinic. We were sharing an office space, and that made sense because it gave us good access to the medical oncologist. We were working with them closely. We could have good conversations about care, and he calls back into that clinic, and an oncology nurse answers, and he says, I have a runny nose. It's really bothering me. And she said, and he described it as clear drainage coming from his nose. And she said, I think you should take some Sudafed. It's allergy season. And that landed in my inbox. Fortunately, the nurse actually, all of those inbox messages get routed to me, and I have to go check. I read that, and I went, no, let's see him back in clinic. We want to make sure that this is truly an allergy. And actually, it was not. And so this is his scan. I rescanned him. Look at all that air. There's a huge amount of air. They had not repaired the dura well, and he had CSF just pouring out of his nose. And so if you've ever seen that, you have them do a tip test, you have them lean forward, and just like it poured out of his nose. And so we immediately admitted him, and he ended up undergoing endoscopic repair of the sphenoid and septoplasty. So really, in summary, the term benign is such a misnomer because even the good ones can behave badly. And the brain is like real estate. When you think about it, location certainly matters and where things are. And all patients with benign tumors need follow-up. So if you're thinking, oh, it's fixed, it's probably not. And we probably do need to make sure that they understand this is a lifelong process with a brain tumor and that you absolutely need to keep your follow-up appointments. And then make sure that all follow-up care, you're really doing a nice job of connecting them with specialists. So if they go home with a really bad facial weakness, are they following up with the right professionals that are going to help them through that? And then this is just an overview of complications we want to make sure that we watch for. So DVT and meningioma, make sure that you read the consent. That actually will tell you, when our nursing staff on the floor, I always tell them, you can learn so much, just read the consent, and you'll be able to do a nice job counseling patients when they're going home. And then make sure that we're preventing exposure keratopathy. That's just really good nursing care. And make sure that the family knows the importance of that, because sometimes they just don't get it. They think you're doing it the entire time. and then advocate for psychology support for them. This is just the mobile app that we have through WFNN, and I hope to see you all in Australia. Okay, thanks. Any questions at all? Okay. You're welcome.
One question for you. So you were talking about meningioma and of course, the frequency of recurrence and the routine follow-up imaging that happens, I guess you could say annually. Would the first choice be CT or MRI for these patients, given the frequency?
We always do MRI for a number of reasons. The CT scan of the brain has the highest radiation of any scan, and so we really try to avoid CT scanning people. We almost always use MRI. It is really nicely imaged on MRI because it's homogenously enhancing, and so you can see recurrence pretty early, and it really depends on the age of the patient. So if we have a really elderly patient and we feel like we've done either a near gross total resection or a gross total resection, we may just say, look, we're done. A young person, a 40-year-old female, that's a different story. And we maybe got a subtotal resection because of involvement of the sinus or another reason, vascular issues. Then those are patients that we would follow much more closely. Atypical meningioma, absolutely follow very, very closely. Any other questions? No? Well, thank you so much.